Welcome, welcome, welcome to tonight's webinar. Just gonna kind of let everybody finish logging in and see how it all goes tonight. I appreciate everyone around the world who is taking their time out from whatever is important, whether that be sleep, family, dinner, lunch, breakfast, whatever that may be. I appreciate you coming in for all the imaging tools for your diagnostic needs. I'm going to give us another about 30 seconds and then we're going to get started. Just let the stragglers get in and then the rest of them will catch up as we go. So, all righty, getting there. And we got that first minute in. And now let us get started. So, all right, all the imaging tools for your diagnostic needs. That's where we are today. My name is Marty Jablow. I'm America's Dental Technology Coach, and I'm here today to give you this webinar and hopefully teach something that you didn't know. You know, one little pearl is all it takes, and you can then say, hey, it was worth my time. So I'm also part of the Celebrant Best of Class Technology Awards. So I'm one of the 5 people who get to pick those awards. And Dentistry Today thinks I'm a CE leader. So that's where I'm at. I'm a general dentist. Okay. I actually treated patients today. I treat patients most days. And I'm also a consultant for dental companies. I lecture, I author articles, and my office is in Woodbridge, New Jersey, and I live where you see that smiling face of Tilly down what they call the Jersey Shore. So that's me. If you've got any questions, this is how to get a hold of me. Marty at dentaltechnologycoach.com. You can go to the website, whatever you want. I mean, it may be on imaging things we talk about today, or it can be on any topic that you think I might be able to help you with. So if you don't get a response in about 24 hours, send me another email because somehow I missed it. Okay. You can also find me online. I have a blog, Dentech blog at blogspot.com, Twitter, LinkedIn, YouTube, Facebook. And if you really think it's worth it, you can Venmo me. I take the money and then I'll donate it to charity. So, you can find me. If you just Google my name, something will come up and you can find me. I want to thank Air Techniques. All right. They are tonight's sponsor of this webinar. Without them, this wouldn't be happening. And they are providing my honorarium for tonight. So the real thing here is in dentistry, and any kind of healthcare, I mean, you cannot treat what you don't diagnose. So the first things that we have to do and we have to understand is that diagnosis is the key to almost everything else we do. Without the ability to do that, we don't know, what we should be doing. So diagnosis to me is the first step of anything. And when we do that, we figure out what we need. All right. Everything else comes from that initial diagnosis. So the question is, how do we get there? And that is the big key. And now it doesn't, doesn't want to move on me here. There we go. So all dentistry starts with an accurate diagnosis. All right. And how do we get there? Like I said, so we usually, for most everything we do in dentistry, a big chunk of it is visual. We need to see what we're doing. We work in this big dark cave called the mouth, but we light it up and we look. That's the first thing we do. Yes, there's a tactile portion to this where we may take an Explorer or, other instruments. But for the most part, most of what we do is visual. And when we start looking for this, we want to look at that complete visual, what I call the imaging portfolio. So that's intraoral, phosphor plates and sensors, extraoral 2D, a pan, a SEP, the extraoral 3D, cone beam SEPs, intraoral cameras, some with caries detection, some without. And then you got to wrap the whole thing up into a nice package. And that's how are you going to, what software are you going to use? How is it going to integrate into your workflows? How does it, interface with your practice management software? All of those things are really, really important. And to me, if I was starting from scratch, the first thing that I'd want to know is what imaging software I would want for my office. The practice management software would almost kind of be secondary. Now, when we get into some of that, there's some, imaging that softwares that integrate better with some than others. Dexis and Dentrix, EagleSoft, and I just drew a blank. And some of them, will do better than others. And, that's the kind of thing that you have to understand. How do those pieces come together? Because that's a big piece now. We spend more time with imaging, especially in the back part of our office, than we do with the practice management software. So getting that together is really important. We have direct integration, and this is an example of smart image with Dentrix. How do these images come in? How do you want to view them? How do you want to manage them is another piece to this puzzle. Do you want to run a single database? Do you need two databases? Sometimes it's even three databases. In my office currently, we're running three separate two imaging databases and the practice management software. Are they being backed up? Are all these things happening at the proper times? You checking all these things to make sure they're working. These are important things to realize. And then if you don't have direct integration, you have to have what they call a bridge. And what that does is it pulls the demographic information from your practice management software and feeds it into your imaging database. And if you don't have the bridge, then you've got to sit there and actually do a manual information, typing it in, which we all would like to avoid. And bridge software is separate software. So, that's a big piece to this. I mean, right now I have my imaging software and then I have my cone beam software, which resides on a different server, which is still linked to all the computers in my office, but it's another thing that I have to back up. It's another thing I have to be aware of and manage and do all of those things. And if I run into a problem, I have three separate phone calls I have to make. I have to call practice management software, or I have to call the imaging software or the cone beam software. And that's just something that, you have to understand when you do that. Then we have what I call single database solutions, which is a lot of times you only have to learn one thing. Everything's in one place. It's simplified training. It's one-stop tech support. And those are solutions that, you want to consider. Again, depending on what your individual office may need will dictate, exactly what that database looks like. So for many years, I did run the, what I call the bridge software, which I still do, which is my 2D database. All right. It's not integrated with my 3D database. So those are two separate companies. I have two separate things to maintain. And, the staff have to learn new software. So again, you have to think these things through as to what makes the most sense when you're, starting out and looking for all of these solutions. But imaging helps us get to these accurate diagnoses, whether it's, as you can see, what's wrong with that, amalgam or your cone beam or the caries on that 2D, bite wing, or, imaging on a pan where you may look at it and go, oh, there's some pathology. So again, all of these things will drive us to the proper diagnosis, which then hopefully gets us to the proper treatment plan. I mean, that's the whole thing. And the other parts to this is when you use imaging properly, you're going to be educating the patient at the same time. In my office, what we do is we have big monitor, 50-inch monitor on the screen in front of the patient. We've got a couple of other monitors also in the doctor's operatory. So there's 3 monitors going at any one time. But we put all that information on front of the patient, and then we go over this information with the patient. So we show them what's going, it's show, tell, do. And, that's really it. And it's really important that you can bring all of these pieces together, because 1, it's going to wow the patient, but 2, it's going to help you explain to the patient exactly what they need to have done. So it starts with imaging. We do use extraoral cameras. In my office, we take a series of imaging. But something else that I do all the time is I use an intraoral camera, because before I put any kind of drill to a tooth, if you can't see it on a radiograph, I want a picture of it, because there should never be a question as to, why you're doing something. We may disagree on what we're doing, but we shouldn't be really disagreeing on the whys. Okay. And, again, a picture like this, does it need a crown? Doesn't it need a crown? What are we looking at? But that's going to educate the patient. It's going to keep you out of trouble also. If there's some kind of, legal thing that comes in, or somebody's got questions, you can easily show these to document your case. It protects you medical legally, and it's just a great thing to have. So, that's a real important piece. You get information from these things. If you're using some intraoral cameras, that do caries detection, whether, it's just another piece of the puzzle. It's another piece of diagnostics. So what I always say is diagnostics are the real important things. And we add all the pieces of our diagnostics up, whether it be, these caries detection cameras, your bite wings, a Explorer, whatever you're using, this all becomes part of that. And then you get all of what I call these data points together, and then you make your final diagnosis. Another really good thing here is when I'm showing that abutment is you take a picture of the abutment when you put it in the implant, and you're saying, well, what do I need that information for? Well, hopefully, and I hope it doesn't happen often, but occasionally something will loosen, and you're going to have to start drilling into a crown. And you're either going on a searching mission to find where that access point is, or you're going to look at a photo and go, I know where the access is. I know where to drill. See, so these are things that you might say, hey, I didn't think about that, but a quick intraoral photo of this will then say, hey, okay, I need to drill, from the lingual more than the buccal, or vice versa. And then you're going to make it easier to find that access, hole. And then you can hopefully then retrieve your abutment, screw it back down, whatever you're going to do. And you've got lots of different choices here with lots of different things that go with them. Air Techniques has their Camex Triton HD. You've got a mouthwatch, a DigiDoc Iris, an Acteon SoPro Life. Some of these come with, with built-in caries detection. Some of them had add-ons. But I always say, one of the things that I definitely have to have in my office is an intraoral camera, because it just does so many things for us. It's the initial part of looking and then documenting for the patient, and all of these things come together. But the first part of imaging is going to be some kind of camera, because that really is what drives everything. Showing that patient that broken tooth and saying, well, there's decay under the cusp and we need to put a crown on it, will probably generate, a better response than just telling them. And yes, I know your patients trust you and everything else, but seeing is believing. But then we get to radiography, and the gold standard in 2-day radiography is still there. I mean, it was film, now it's digital, but this is the gold standard. This is the stuff that we do all the diagnosis from. And, at this point, there's less than 10% of the dentists in the United States who are still using film. There are still holdouts out there, and Kodak still sells it, but, it's a dying situation. Then we have our direct digital sensors, and then we have indirect, which is phosphor plate systems. I have had both in my office. I continue to have both in my office. We started with phosphor plates. many, many years ago. And obviously we've transitioned to sensors, but we still maintain a phosphor plate, working in the office because we want those just in case, and you'll see why later. So again, you may have a different, situation, but it can be a sensor, and the phosphor plate scanners. The boxes come in all shapes and sizes. It depends on what you need it for, what size films, as I'll call them, or plates, and what your needs are. And they come from everybody. This is not a total list, but here's some. And as I was talking before, Schick is the one that integrates best with EagleSoft, and I couldn't remember. But again, Dexys and AirTech and Vatec and CareStream and Schick and Gendex and there's a whole bunch of people who make sensors. The reality is, in many cases, there's only a few companies worldwide that actually make sensors. In many cases, they're just rebranded, but you have to understand what you're getting with it. And that may be tech support, integration with their software. What do you already have? How is it going to integrate? These are important questions to think about before you make a purchase. Will what you buy integrate into what your software is? So let's say you're running Dexys. How easy would it be then to add an XDR sensor if somebody gave you one or you decided to buy one, or vice versa? What's that software situation look like? And it's really critical to think about that, not just for right now, but for the future. The best sensor today may not be the best sensor tomorrow. And if you can't easily integrate that sensor into your current imaging software, that could present a real problem. So it's something to think about. Advantages of sensors are, they're very fast. They're faster than phosphor plates, obviously. You're directly connected to the computer. Although they talk about it being an instant, image, it's not. There's a slight delay, but it is faster than phosphor plates. It has a higher resolution compared to phosphor plates, and they're very diagnostic, when used properly, like everything else. Who's taking them? What's the X-ray machine? What's, what type is it? 70 kVp, 60 kV, whatever it may be, important parts to this. So you have to understand your entire radiography situation. All right. There's some disadvantages. They have special holders. They obviously cost. What's the maintenance on them? And some companies charge a pretty hefty sum for maintenance. In some places, it's more difficult to acquire the images, and that's just a piece of the puzzle because some of these sensors are thicker than others. None of them are as thin as a piece of film or phosphor plate, and some of them do other things. In other words, they'll look at it, and here we're looking at a Dexys sensor, which is an excellent sensor, but as you notice, all the corners are cut. Well, you're going to miss information in those corners. So is that really a number 1 size, a number 1.5, or a 2? All right. If you were to take a number size 2 film and hold it up or to that sensor, which one's bigger? So again, there may be a trade-off in some of these things when you start looking at them. So you have to understand what that actually is. And as I like to put it, one size does not fit all. It fits many, but it doesn't fit everyone. And that's the reality when we're talking about, sensors, is that, is it going to work? Is it going to fit? What are the limitations potentially of just because it's thick and it doesn't bend? My perfect example is this. I don't know of a single sensor that will fit in that space. All right. It's too small. Can I fit a phosphor plate in there? Absolutely. All right. So, in a situation like this, you're kind of limited to either placing a phosphor plate in that space, or you're going to need to take some kind of extra oral bite wing, because this patient will never be able to bite down and get you a good bite wing with a sensor. So it's something to think about. What are those limits? What about, pediatric patients? What are we going to do with all of them if you've only got a number 2 sensor? So one of the things that you may want to think about is what I call dual systems. Have your sensors and use them, on patients that it's easy to use with and everything that goes with that. And maybe consider having a phosphor plate system. One is a backup, all right? Because if you've only got one sensor and it goes down, you need something else. Because I like to say, if it goes down and first thing in the morning, you lost radiographs for the whole day because they won't get you until the next day. Companies usually will overnight it. If it goes down at 5 o'clock, you may be out, the whole next following day and into the second day until, one of the services, FedEx, UPS, or post office delivers it. So, having a good backup situation is something that's really something you want to consider. Here's again, some companies that make phosphor plate systems, and you can use these just like you would, film. You need that, what I call the digital developer, which is the scanner. And so this is the box. You put it in if you still have an old dark room, you can put it in there, but you can just keep it in an operatory. It's not a problem. It's nothing new you have to learn. Everybody was trained, whether it was on film or digital, it's still the same workflows. The plates are similar to film. They have, multiple sizes, 0, 1, 2, 3s, and 4s on occlusal film. They even go up to, steps and in panoramic films. If you have an old analog, again, I'd suggest, potentially upgrading. But if you still have it, a phosphor plate system may be something you want to consider. Although I would highly recommend not buying it for something like that and just going out and getting a digital pan if that's what you needed. But again, compared to a sensor, obviously the plates are thinner. They're flexible. You can you don't want to bend them, but you can, put them in and they do have some flexibility. So in that patient who had those big tori's, that would easily fit in. And again, you can capture all different kinds of images depending on what your needs are with a phosphor plate system. Now, not every phosphor plate scanner can accommodate every size of, plate. So when you're doing this, you have to consider that also. Are you going to be using, occlusal films? Will that fit into the scanner? Most of them will take a number 1 or 2, but when you get to these other sizes, you have to understand that, you have to buy the proper scanner to be able to take those other images. So again, why not both? It gives you the flexibility. It gives you the redundancy. It gives you the ability to take, images on anyone who walks into your office. And then we get to panoramic imaging. This is a big piece too. There's a lot of pathology that's missed when we start just looking at, an FMX or a set of bite wings and a few PAs, because there's lots of things that go on beyond, as I say, the teeth. And taking a panoramic image just enhances our ability to see things beyond that. And if you don't have a pan, you'll be surprised how often you will find things that just don't, belong. Whether it's a cyst, whether it's a broken tooth that's still, it's still been buried in the gum and no one extracted it. But again, that you could find on most things. It's the stuff beyond the teeth that you really need to be looking for. And so why would you want a pan? All right. Well, in many cases, it can be a full mouth series replacement. It's great for trauma, looking at fractures, as patient falls, what's going on with their jaw. Obviously, for orthodontics, implants, third molars, from my end, it's the standard of care. You need at least that to be able to image the whole thing. And again, you're going to find a lot more pathology when you come to a panoramic film than you will just on a full mouth series of number 2 films, because it just shows you that much more. So again, they come in all shapes and sizes. Some of them, you can, if you need a SEP and you're doing orthodontics, obviously they have the SEP arms that can be included. And, this is all digital now. I mean, you don't have to sit there with films and develop and everything else. You can just do what you need to do, take the images that you need, and, they're stored. And then they're stored forever, as long as you have access to them. I mean, it was interesting. I had a patient come in last week who had not been to my office in 17 years. All right. But we were able to pull up radiographs. It was interesting, but we had access. And that's something that you have to understand, that it's easy to keep those backups. If not, her chart would probably have been, tossed a long time ago with all the images in it. So, that's one of the benefits. And again, you've got the SEP if you need it. And again, for difficult cases, these extraoral bite wings are better than nothing. I'm not a huge fan of them, because they're not quite as diagnostic as a regular bite wing would be from a number 2 film. But, when there's those patients that you can't get that information on, the gaggers, the people with those big tori, all of these things, the people whose tongue keeps pushing the thing out of the way. So this is something that it's better, as I like to put it, it's better than nothing, but it's another modality that's going to help you, when you need it. These are good also, if you're just looking to, check, you don't need a full pan to check, whatever, an implant placement or things like that. I mean, this is a vertical bite wing, and you get to see everything with it. But again, I don't consider them to be the same diagnostic value as a regular, number 2 bite wing. So the advantages, most of the patients love it. I mean, as I like to say, whether it's a phosphor plate or whether it's a sensor or a piece of film, they always talked about what's more comfortable. And I think if you really dug down into it, you'd probably say none of the above, because it's just not comfortable having this thing stuck in your mouth, digging into the floor or roof of their mouth. They're not comfortable. So one of the things that definitely is an advantage is that the patients tolerate these extraoral imaging situations better. It's a little more complex for most of the assistants taking these images, and we have to be aware of some of the limitations of that. But again, it's just faster acquisition time. They get the patient set up. We get in there, we look at it, and again, it comes up on the screen quickly. So there's a lot of advantages there. And again, with that broad anatomical coverage, we get to see things that we wouldn't otherwise, the 4th, 3rd molar, and some of those things that just kind of are out in left field, and we get to see them and we get to deal with them, and if you didn't know it was there, and it just becomes more difficult, down the road. So, very important that you take advantage of those things. So the disadvantage of a panoramic are the images aren't as fine detailed as regular, intraoral FMXs, and that's just the trade-off. There's nothing you can do. So it's really not good for caries detection. It's really not good for looking for, non-displaced fractures. That stuff just doesn't do well with, the extraoral imaging. Endodontics, again, panoramics, aren't going to give us that detail that we would really want or need to get, good, accurate looks at, the gutta percha placement and that kind of stuff. Perio, again, for placing implants, it may be adequate, but for, everyday looking at, bone loss and calculus and things like that, that may be some gingival, not the best thing. But the most critical part, which I kind of alluded to before, is positioning the patient. whereas you're taking some bite wings and you have the bite wing holder and everything gets lined up as long as you got your, rin holder in the proper place. Positioning for, a panoramic can be a little bit more difficult for the assistant, especially if you have large patients or very small patients. All of those things impact, placement. Tall people, short people, whatever those may be, are going to impact how you position that patient. So a real critical part to this is make sure, no matter what you do, that the patient is positioned properly. And that, will give you a better image if they are, but it takes a little bit more work to get it there. And then we come into our 3D. All right. This is real state of the art now, but it's standard. Lots of people have them. I remember it used to be, something that you sent out. It was sent to a radiology center. And then we had, a couple of offices start to get them, or a mobile van or something that, was going to get us our 3D imaging. And now lots of offices have them. It's part of what we do, especially if you're going to be placing implants, doing, good endodontics, retreats, things like that. Something to be aware of. So, an example like this would be, hey, where's it going? Do you want to take that tooth out? And what would be the issues with doing that? So medical legally, it becomes an important part of having some of these types of imaging, so that you get into if you don't get yourself into a situation that you could have avoided. That's a big thing. Do you start treatment with, on an endodontic tooth that may have a J-shaped lesion already, and the odds of failure are quite high? So cone beam to me is the big picture. It kind of gives you this big overview, and it shows you all these different things, and you then have to determine what comes with that. What's the important part to this? And, again, see the things that you wouldn't see otherwise. Just kind of the way I look at it is that when I use the cone beam in my office, it's just kind of, wow, what is it? What am I looking for? And again, most of the stuff that I'm looking for isn't necessarily pathology, although you have to be very aware of the fact that no matter what images you take, and the greater field of view, and we're going to discuss that in a moment, you are responsible for reading everything. That doesn't mean you have to, make the accurate diagnosis, but what you have to do then is, if you see something that's not quite right, you need to be able to go back in and go, hey, Mrs. Jones, you need to see the oral surgeon, the ear, nose, and throat specialist, whoever that you think that they need to see at that point. You just have to make the appropriate referrals. So the limitations of the 2D x-rays are superimposition. And if you take this simple picture here, as you can see, depending on which way you were looking at this woman is holding a banana in one hand and a pineapple in the other. Guess what? You don't see one in one view and you don't see the other in the other. So, we lose a lot of information that may be valuable to us when we're doing standard 2D x-rays. This is just the fact of what it is. And, when we want that, we want to see the whole thing. We want to see 360, because that's the information that we're going to need. All right. So this is a great slide. It kind of gives you, an idea in a different way of what we're really looking at. And so, we talked about the panoramic, and it's just this big slice that looks at all the teeth in 2D, and it just gives it to you. Versus the axial, as you see in the middle, it's spinning down, and you can look through those layers at the teeth. And that's an excellent way to try and, determine endodontics, especially when you're looking for, your MB2s and your maxillary first molars or second molars even. If you know what you're looking for going in, then you have a better chance of finding it. Let's say you see that, that MB1, and now you see the entrance for the MB2. You can actually measure that and you have a really good idea where it is. So what you're doing then is when you're troughing into this tooth, you've got a pretty good idea of where you need to be. It's not just searching and going, let me see if I find it. It's knowing that it's there ahead of time and where it's located. In many cases now, there's even guided endodontics where trying to limit the size of the access opening to keep, more tooth structure, keep the tooth stronger. And we can do these guided endodontic procedures now. And then your cross-sectional slices, you can see there, is looking through the tooth in a, incisal to or occlusal to, root situation. But I think that slide kind of gives you a good idea of what that kind of all looks like and, what to expect. So, the first thing we talk about is large field of view. And people like this because it gives you everything. And in many cases, unless you're doing orthodontics, maybe you're doing sleep medicine if you're trying to measure airways, this is beyond what most dentists would need unless you're doing those things. So in that large field of view, you can actually take a SEP out of this that's reconstructed, and you can get a SEP out of it. So, that may, when you look at that, and again, it's proper training on how to use all of these things. But when you put that all together, you may then say, hey, I don't need to spend another, whatever that may be, $15,000, $20,000 on a SEP arm. I can just use the cone beam to reconstruct the SEP. And there's, from the orthodontic perspective, there's people who say that's adequate. And then there's other people who say it's inadequate. So as I like to say, for those who are looking at that situation, you better do your homework. This is also the view that may be the most, the one that would give you the most liability, all right? Because we're now looking into spaces that as dentists, we're not used to looking into. So identifying pathology in these patients may be a bit more difficult. If you've got issues with identifying that pathology, then you may want to consider sending out these scans to a radiologist who is then going to read them, write a report, and sign off on it because, hey, it's your liability. Who's going to take on that, role? So it's something to consider. Medium field of view is what I kind of call the normal in dentistry. And this is the stuff that's, really looking from the nose down to the chin and back to the end of the ramus. Usually it will still encompass the fossa, the TMJ, so that you can kind of do pretty much most what I call regular general dentistry type of situations, along with feeling a little bit more comfortable about potential pathologies in these areas because it's limited to something that we are very well versed in. If you've been looking at PANS, for years, you would understand where these pathologies are, cysts and other things that may be cropping up. And to me, that's really something that you would be aware of. So, a medium field of view to me is just like the perfect field for most general dentistry. You can also get what we call a focus field of view. And there's some CBCTs that you can dial in everywhere from a very small, like a 5 by 5 centimeter area, all the way up to that full view. They're obviously more expensive machines to do that, but you can do what's called a focus view and just, concentrate on one area. If you're doing endodontics, this is an excellent way to take a small field. You can actually then take what I call high image, where you're going to get a lot of fine detail. All right, because for endodontics, that's kind of what you're looking for. You don't need a large area, and you can then just concentrate on that one with extremely fine detail that you wouldn't need for, let's say, implant placement. So that's focus. But then what you can do, and I would suggest not doing, is you can stitch all these focused areas together to get a bigger, image. This was kind of done more years ago, but there's still machines out there that do this. I would kind of shy away from this type of situation, strictly because there's errors that are going to be introduced potentially by stitching all of these smaller areas together. I'd rather have the machine come through, take the one image, see everything in one, then take a little bit here, a little bit there, and have these overlaps, stitch it together. So if you're doing implant placement on a machine that's stitching things together this way, would not be my first recommendation, strictly because they may not be as accurate. So again, all of these things can be selected, and we talked about it just before, is what do you need? Can you select it? What are the sizes that are offered by that CBCT? And what are the advantages of taking bigger or smaller images? And again, we can get all kinds of different images here. Again, implant placement, see where you're going. If you look at the image on the lower right, you start to see that there's no bone in that one area. This is not a good thing. I use this all the time, for, judging implant cases. And whether I'm the one placing it or the oral surgeon or the periodontist in my office, it's just a real important piece of that puzzle. Again, these can be used in conjunction with guided surgery, where you're going to use specialized software to take your DICOM images, place your intraoral scanning image, overlay them, and be able to then accurately develop a surgical guide. And again, very important, especially in areas with less than adequate bone, where it's not quite so simple, or you're threading the needle, as I could put it. And you have to remember too that just because we're using a CBCT doesn't mean we're always giving people big doses of radiation. I kind of look at this: if you still got those old SS Whites sitting on the wall in your office of intraorals, they may be actually giving you a higher dose of radiation than maybe even a cone beam compared to a full mouth series. You really need to understand what your machine has, what your machine is using, how new it is, and again, trying to keep the amount of radiation to the lowest possible amount, and that's just part of the ALARA principle. We don't want to over-radiate patients, but we don't want to actually keep coming back and taking images. Now, some of these cone beams, actually, you can take they'll take a photo and overlay the cone beam. This is really good for orthodontics or orthodontic surgery if you're trying to do different things with that. But even these days, you can actually, with implant placements and 3D scanning of faces, overlap all of these things. So you just keep layering, and you could have the patient smiling and be able to see all of this, down from the soft tissue of the face and lips to the teeth to the cone beam images. All of that can now be integrated, and it's something that is just getting to be more and more mainstream, and allows us again to do better diagnosis. So some of the benefits of CBCT: again, guided surgery for planning. Do you have adequate bone? Even if you're not going to be using a guide, do you have adequate bone? What size implant will fit in that space? What's the angulation? All of those things can be determined by simply, looking at your cone beam image. And then if you want to, you can get a guide made. You can either send them out and have them printed, or you can, in many cases now, we can print them in our own offices. The 3D printers have come down significantly in price, and then lots of, offices are using them, not just for guides, but night guards and, temporaries. And even now, there's some newer materials that are coming out where you can actually make some crowns out of them, or all on 4 type prostheses and things like that. So printing is a big deal now, but again, it all starts with the benefit of having the cone beam so you can get the implants in the right place. Endodontics is a big one here. We've all seen, 2D images like the one on the upper left. or, looking in that furcation on the one on the upper right and saying, hey, wait a second, what's going on here? All right. And we go, we're going to leave it. We don't know. And then when you start getting into the cone beam images, you can actually see that what was missed here, and the reason for the failing endo, was that there was a fourth canal in this, lower first molar, and it was missed. And, that allows us to consider going, okay, was this adequately treated initially? Do we only have to go in and clean out the one? Do we want to take out all the gutta percha and retreat it? Whatever we're going to do, but it helps you determine what you need to do or what the reasons are for the failure before you ever get in there. So, in this case, exactly what happened from your diagnosis with this imaging. You're going to see missed canal. Missed canal means I got to go back in there and clean it out. Well, there you go. Accurate diagnosis makes for easier treatment. And that's, one of the things that you would see here. And there's where that fourth canal was missed. Again, this oral surgery case, here's different things here. We're looking at, what would happen here if you took that out without knowing where the nerve is. That would be a problem. Where's the nerve located? In this case, the tooth is, not near it. Again, these are important things to be aware of. So it's a good thing when you're going to do surgery to know everything that's going on around these teeth so that, again, you don't wind up with a problem that you don't need. How about this one? All right. If you were going in there to try and take this out, look at that hook. Are you really going to just hope, you start tugging on that? And why isn't it coming out? And what's the surgical, things that you're going to have to do to get that out and not have that, potentially get pushed into the sinus? So again, when we start looking at all the information, again, it will give you those things that you need to know to help you prior to getting involved with it. And that way, again, you may be easier, or it might be something that you would have normally done yourself and then decide to refer. But these are all important pieces of the puzzle, especially when you can see them and not have to be guessing. Again, when we come down to airway, if you're doing airway measurements, can we do it? And most of these software set up in these cone beam systems can do these type of things where we're going to be able to measure your airway and then see what kind of results we get. And here's a rapid palate expansion in a child. And as you can see, their airway, was significantly enhanced just by doing this palatal expansion. So it's not just at that point, it's just not a total diagnosis. It's, seeing how much benefit you're getting from the treatment that you did. So that's, again, cone beam is just growing in what we use it for and how we use it. And it's, in many cases, you have to just kind of think about, what do I need it for and what's its benefits going to be? In my office, the cone beam is used quite a bit. Again, mostly, third molars and implants, but, occasionally I have to do the retreat, or I'm looking at an endo and I'm going, I'm not sure, even in the middle of it. And we'll get the patient over and take the cone beam, and, then I can start looking at it and see, why can't I find the canal? That's really what it comes down to. So, that was your imaging in a nutshell, from intraoral cameras, intraoral images, through 2D, panoramic, 3D. And now I'm going to go up here and start looking at some questions that were there. You can start, typing in more, and I'll be happy to look at them. Let's see here. Would it be okay to take bite wings with the pano machine? Pano machines, like I said, I don't think they're the standard of care for a set of bite wings. It's not something that I would use specifically as number one go-to. But if I can't get bite wings any other way, then of course I'd rather have something than nothing. Especially in some of those patients that I have that just acquiring the images is extremely difficult. I got one guy that I can think of. I mean, he gags before you even get to him. And to him, he thinks this is a godsend, because everything was a struggle. The tears would be coming down his eyes. And now, we have to deal with that. But, now with him, it's simple. So again, I think it's a good idea, to do. Next thing is back to the same things. He says, using the Pano machine to take bite wings for patients with tori difficult. That's, again, perfect thing. I mean, pedo patients, it's a little bit easier, but again, it's not quite as diagnostic. Again, depending on your staff, you can hopefully get a couple of bite wings even on a pediatric patient. You got to remember, it's again positioning and everything else with the pan for these bite wings. Will the child stand in place, and not fidget around too? So there's no perfect situation here, but it's something you can consider. Can caries be detected on a CBCT scan? And the answer to that is not really. You can see it if it's large enough, but those small interproximal lesions, the small occlusal lesions, would be difficult to find on a CBCT. So that would not definitely be my first choice. And also, again, back to the Alara principle, you really don't want to be scanning these people for caries. In most every case, the CBCT can reconstruct the pan, but the pan again isn't meant for caries diagnosis. That's really it. There's a question here. It says, "What about Altero?" I'm not sure what that question is. If you want, type in a more detailed question. I'll try and answer that. What course would you recommend to take before getting a CBCT so one can interpret them adequately? Ooh, that's a good question. There's a whole bunch of stuff online where I'm trying to think who's given it. Plan Mecca does one. Prexion does one. They're almost CareStream does some on diagnosis using CBCT. There's other. I'm trying to think who else. I think there's an implant company. I'm not sure which one. I'm trying to think. If you get back to me, I can probably look it up. That also does a class full day of cone beam interpretation. So I would start online. You might start on YouTube, but look at these companies that are selling them, because in many cases they have good education that goes with it. But I do know that I get something pretty much, I think, from Prexion and Plan Mecca almost monthly. CareStream 2 throws them out there again pretty often as to use its diagnosis. That's really what it's about. So that's where I would start. There's a guy named Dale Miles, friend of mine. I'm trying to remember his. If you just Google him, it'll come up like cone beam reader or something like that. He may be able to direct you in the right to the right place, because he also has written a book on cone beam. How often do you take recall X-rays? Every 6 months or 1 year in general? So in my office, we normally take recare X-rays every year. The recare X-rays would be, 4 bite wings, 2 anterior PAs, or anything that we think might be necessary based on a patient's complaint or something along those lines. We do that yearly. In some patients who, have a history with no caries, again, we might push that out to 2. But, during this COVID issues, we had some people who obviously put things off for quite a while. And we saw many patients who had, very incipient carious lesions, just blowout teeth. So, to me, trying to do that every year, I think is good practice. Every 6 months might be a little overblown, but again, in a high caries individual, that may be something you want to consider. I would tailor the radiographs to the patient, not to the time, as part of it. But as a general rule in my office, it would be 1 year. What would be the first imaging device you would invest in outside of a digital X-ray sensors in a new office? Oh, that's easy. Intraoral cameras. they are going to make you money, save you time, and protect you medical legally. So I would really, really, consider that. That would be my next go-to. Obviously, you need your digital x-rays, but then the absolute thing would be the intraoral camera. And I would get that before I would go to the pan or the cone beam. And obviously at this point, I would probably tell most people, you really want to go to the cone beam because the extra stretch right now for the cost is well worth the information you get, and you get the pan with it. So again, consider that, if that's what you're looking for. CBCT interpretation resource course for the radiologist to read it. All right. So there's a lot of third parties out there that will do it. Cone beam readers is probably the easiest one to deal with, and they're probably the best well known. You're looking at, depending, you can buy them in packages to lower your cost if you're doing lots of these and you want them to read them, but it's $100 or less, and sometimes they're $80 or less. You can go outside of those situations and find, individual radiologists. And, again, you can negotiate your prices on that, but that's probably a pretty good idea. It's under $100, and you can probably find them for somewhere in the 60 to 75 range. So back to that, the question, which was iTero, and said, do you use it in your office? It's for diagnosis too. Yeah, some of the intraoral scanners now, not just iTero, you can check things like where there's the CareStream and the Trios, and the Plan Mecca also have caries detection built into them. So again, when you take all of these digital tools and you put them together, again, it gives you more and more data points, and those data points help drive the best diagnosis that you can have based on what's going on with the patient. That's really what it comes down to. We always have to remember, this is about the patient, not anything else, not us, not the technology. It's about the patient. And then once we know what the patient's problems are, then we use all the pieces of technology that we have at our disposal to try and get the most accurate diagnosis. So again, in kind of putting this all together, again, I think an intraoral camera is a real necessity. If you need or want the caries detection built into them, it's something to look at. When we're looking at 2Ds, obviously a digital sensor is number one on my list, but you also have to consider having a phosphor plate, because that's really something that may have come in handy when you need it. And then when we get to the last parts, you get to the panoramic, which is, again, kind of what you need if you're just even thinking about doing some implants, and cone beam obviously gets you the rest of the way. A couple of last quick questions here. My thoughts on a Diagnostic. I had a Diagnostic years ago. It was back, early days of practice. I think it's a great piece of equipment. And when used properly, it definitely can help you diagnose. Again, I'm not sure that that's state of the art today, but it sure as heck did work and does work. Is 2D radiograph still the accepted standard of care? Absolutely. It's the gold standard. Everything else comes, after that. But again, knowing what modalities you need to get what you want, that's it. Pick the right thing. So, a 2D radiograph to place an implant may be fine if you're real good at doing it, you want to do it freehand. If you've got a difficult situation, obviously a cone beam is going to make your life so much easier. So I just about took this whole hour up. I want to thank everybody for coming in here and, giving us your time, because that's the thing that's valued the most. So with that, I want to say thank you to those in North America. Have a good evening, and everybody else around the world, have a great day for wherever it is, starting or ending. So, all right, again, thank you very much, and hope to talk to you all again some other time here on Viva Learning.